I want to talk to you today about the people who are on Medicare, who they are, and what the effect is on that population of some decisions. This is who we are, California Health Advocates, and we provide technical assistance and training to groups and people who help Medicare beneficiaries in California, including the HICAPS, which is our state health insurance counseling and advocacy program. This is part of the SHIP network, the federally funded insurance counseling programs, and each of these can be a support to you and provide you with some resources and assistance when you're writing stories about Medicare beneficiaries, because these are the people who work with the Medicare beneficiaries in their own communities. In California, it's called HICAP. The SHIP designation is federal funding through CMS, but they have different names in different states, but they're all federally funded, all have federal funding, and provide free and objective counseling to seniors. So that's where people go, like right now, when Medicare beneficiaries are in the annual enrollment period and trying to figure out if they need to change their plans or not. This is where people go for help. There's a huge knowledge deficit out there about Medicare. And as you heard earlier, seniors the majority of seniors are against Obamacare, health care reform, in large numbers, were before it passed and are now. They don't understand their own Medicare benefits. And I've seen, and I'm sure you have too, seniors with buttons that say, keep the government out of my Medicare. I mean, they don't understand their own program. They're the only group in this country that has a national insurance program. They don't know what's covered. They don't know how it works. They particularly don't know about the free preventive care services and some of the things that were part of health care reform. So they don't get those services. And one of the reasons they don't get for preventive care services, even though they're free, is because they're wrapped up in paid services. So you have to go to your doctor, have an office visit, to even know that there's a free preventive service that you could get that the doctor would then send you to. They don't understand anything about how the cost sharing works, and in part because most of them have some way of covering that. They certainly don't understand how Medicare is financed or anything about the premiums. They don't, for instance, know that the Part B premium that they're paying is only 25% of the cost of that program. And if you try to explain that to them, they are absolutely horrified to find out that the premium that they're paying isn't covering that total cost. They don't know about low-income assistance programs, and that's part of the reason that many of the people who are eligible for extra help aren't enrolled in those programs. And then the public, it's beyond the Medicare beneficiaries are equally confused about Medicare and don't know anything about how it works, often confuse it with Medicaid, and that has implications for those baby boomers who are trying to help a parent with one or more Medicare issues. So I'd like to put a face on this. We have 46.5 million Medicare beneficiaries that include not just the elderly, but the disabled people under 65 who have Medicare, and some of those with ESRD, permanent kidney failure. And the fact that for many older people, Social Security is the sole source of their income. Half of all Medicare beneficiaries live at 200% or below of the federal poverty limit. And the average monthly Social Security benefit, you can see there, is very low for people who are trying to live in a community with all of the expenses that you have running any kind of a household. And almost 10% of or almost 10 million Medicare beneficiaries are also eligible for Medicaid, which in some programs makes them a dual eligible, and in other types of programs pays for things that are not covered by Medicare. This group of people have chronic health care needs. Many of them have 2 or more. 43% of 3 or more. The cognitive deficits in this group is one of those chronic conditions. And as people get older, particularly in their 80s, they're more likely to have that as one of those chronic conditions. A large number of Medicare beneficiaries are not filling their prescriptions, even with Part D, because the plans can put these specialty drugs, on a specialty tier that has a very high cost. And I have an example here of a woman who was being treated for cancer, went to have her prescription filled, and couldn't afford the $2,400 copayment for that drug. And she's not alone. There are many other Medicare beneficiaries with chronic disorders that require very expensive drugs, and in some cases they can't afford to fill those, and because their income is just a little bit higher than many of the public programs that would help them out, they don't qualify for anything. Or they may have some resources beyond the amount that they're allowed to have in a particular state. And this is one of the reasons that some Medicare beneficiaries are spending large amounts of money for out-of-pocket costs that are 30% or more of their income. And these are some of the things that beneficiaries are paying for. There are services not covered by Medicare. And dental is a really big expense. And of course, older people have more need for dental care often even than younger people do. And some of those folks are going to other countries for that care, particularly Mexico, because they can get dental care there much cheaper than in the U.S., but it's still a very expensive process. Medicare doesn't cover vision, it doesn't cover hearing, which means hearing aids aren't covered, and those are very expensive. It doesn't cover long-term care when people are in a nursing home or needing home care that Medicare doesn't cover. And that's probably, one thing to think about in terms of this whole discussion about, the appropriateness of care and whether or not certain procedures should be rendered to Medicare beneficiaries. This was the crux of the whole death panel's discussion, which was simply a way to reimburse physicians for having a discussion with their patients about end-of-life planning. You will hear seniors say all the time they don't want to die in a hospital hooked up to machines. And yet many people have not had that discussion with their very own families. They've not taken the steps to make sure that people know that that's how they want their lives to end. And often when older people are going to the doctor, it's not the older person asking for a particular procedure because they may not even know it exists. It's more often the reverse, where the medical community makes decisions about the care that's necessary and then tells the person that that's what they need to do. And because of the way that this population views doctors, and seniors have a very high regard for their physicians, they don't ask a lot of questions. They don't challenge medical professionals about the things that they recommend. And they are often being told or are having procedures prescribed for them that if they knew more, if they had more information, they might not even agree to that if they had discussions with their families. And part of that is not just the medical care that's covered under Medicare. It involves the kind of things that happen to people when they enter into that long-term care system. And that's a whole other discussion, but that topic of long-term care is a very important part of people's planning. You can see that, the average out-of-pocket expenses for many Medicare beneficiaries is a good percentage of their income. And they spend that money not just on things that are not covered by Medicare to start with, but for premiums. They pay a Part B premium. They pay a premium for Part D. They pay a deductible, and they pay co-payments as part of their Part D benefits. Most Medicare beneficiaries have some supplemental coverage, whether it's a retiree benefit or a Medigap policy or they're in a Medicare Advantage plan. There are costs associated with all of those things. And that all is part of their health care spending, and often those costs are not calculated as being part of their out-of-pocket costs. Because often when out-of-pocket costs are being calculated, they're not including premiums. They're talking about the expenses that consumers pay directly for health care and ignoring some of the other costs that people have who are Medicare beneficiaries. The cuts that have been proposed through the deficit reduction and now the special committee, and some congressmen and some senators and other public policy groups, all have one single purpose behind their proposals, and that is an intent to cause more out-of-pocket spending for Medicare beneficiaries. Every single one of those proposals shifts more cost to Medicare beneficiaries. There are proposals to add co-payments to nursing home and home health care. That targets the sickest and the frailest of Medicare beneficiaries who use those services. There have been proposals to increase the co-payments, which are now, that should say 20% to 30%. That's a typo there. It should say 20% co-payments to 30%. There's a proposal to eliminate the balanced budget, the balanced billing restrictions, so that doctors and other providers could charge whatever they wanted to above the Medicare approved amount. Today, balanced billing is limited to 15% above what Medicare approves. That would open it up to any amounts that providers wanted to charge above the Medicare approved amount. There are proposals to discourage any first dollar benefits, and one of the reasons for this is that many people believe that Medicare beneficiaries overutilize Medicare services if they have benefits that cover their out-of-pocket costs. And so this has taken on the tone of seniors need more skin in the game so that they won't overutilize healthcare services. And some of those proposals include one that would prohibit Medigap policies from picking up any of those costs. There have been proposals to change the tax code to discourage wraparound retiree benefits, to add deductibles and co-payments to TRICARE for Life. That's a program that military retirees are entitled to if they have 20 or more years of service. They and their dependents are eligible for TRICARE for Life with Medicare. They don't pay a premium for that program. They don't pay co-payments, the Medicare co-payments under that program. This would add those costs to that program. There are proposals to increase the Medicare premium to 15 to 30% for those who have Medigap coverage that pay for those first dollar benefits. There are proposals to increase the Medicare premium for higher income people. Right now, those income thresholds are frozen. $85,000 for individuals, $175,000 for couples. Now, this is a group that's not only old, but for the most part, retired. And so when you look at these thresholds for income when people would be charged higher premiums, which they are today, by the way, you have to wonder what's the rationale for that income threshold because when we talk about tax reform as part of deficit reduction, we're talking about individuals with incomes of $250,000 for people who are working. So what's the rationale for those two radically different income thresholds when one group is retired and the other group is still working? Fee-for-service Medicare pays for each billed procedure. Providers that do more get more. I mean, that's been part of the problem. But for the most part, that is not Medicare beneficiaries generating requests for procedures. It's more often that people go to the doctor, and as a result, a doctor decides to do certain tests or that they need certain procedures, and those are ordered, and people generally comply with whatever their doctor is ordering them. And you have to remember that people in Medicare fee-for-service tend to be older and sicker than those that are in Medicare Advantage plans. And 90% of them have some form of supplemental coverage, as I said, whether it's a Medigap, a retiree coverage, which would include TRICARE for Life, the Federal Employees Health Benefit Plans, or something through a private employer. It could be Medicaid or any other low-income program that's available to people in a state. It could be separate VA benefits, which some people have. It might be Medicare Advantage, and sometimes people in Medicare Advantage programs leave those programs because the combination of deductibles and co-payments actually costs more for a person who has a chronic illness than being in Medicare fee-for-service with another supplemental benefit, either a Medigap policy or some other form of supplemental coverage. The last two slides are just a compilation of something that's on the Kaiser family site, and it talks about what happens when you shift things in one direction or another. So, for instance, if you were to increase the age for Medicare up to age 67, then people 65 to 66 are going to have to turn to some other kind of coverage. And this, the paper that Kaiser Family did, assumes that when in all this data that the ACA would have been fully implemented. And so 48% of those people 65 to 66 would turn to employer coverage, either as an active worker or as a retiree. And the claims experience for that group would change because this group has higher health care expenses than younger people, even though they have less health care expenses than people much older than them. 38% would get coverage through the exchange, and as a result, they'd pay higher premiums than they would pay if they were in Medicare. There might be low-income subsidies for some, but the adjusted gross income for this group, for that program, has just changed because they've agreed that Social Security benefits will be counted as income for this group in determining whether they're eligible for a subsidy or not. The premiums would increase by 3% for all adults in the exchange as a result of these older ages being included, because it would reflect the higher claims costs than younger adults are likely to have. 20% would be eligible for Medicaid, which would increase costs to states. And again, there'd be low-income subsidies for some, but not as great as there would have been with the recalculation of the MAGI, the maximum adjusted gross income. The claims experience within Medicare then would be spread across an older, sicker group, and Medicare Part B premiums would increase as a result of that by 3%. And so the projected federal savings in Medicare would then be offset by all of these things. The federal premium and cost sharing subsidies, the expanded coverage under Medicaid, and reduction in Medicare premium receipts as a result. And so with that, I'm going to stop here, and I think we're going to take questions, right?